Please welcome Assistant Secretary of Defense for Health Affairs, Dr. Jonathon Woodson, and APHA President, Dr. Shiriki Kumanyika.
Wonderful. Well, this is part two for those of you who are still here and tuning in. I wanted to have an opportunity to introduce two more wonderful panelists that we have, and I'm so grateful to both of you for being here with us today. We are, as you know, talking about the National Prevention Strategy, which is why I am so happy to have Dr. Jonathon Woodson with us today, who's an Assistant Secretary at the Department of Defense. Many people hear the Department of Defense and they think, what does defense have to do with health? Well, that's what Dr. Woodson is going to help us elucidate, and he's going to share some wonderful examples of what the department is doing to advance health. Dr. Jonathon Woodson oversees medical policies, analyses, and recommendations to the Secretary of Defense and the Undersecretary, and he offers guidance to DoD on a variety of medical issues. He also administers the Military Health Service, which is a $50 billion operation in the Department of Defense. And MHS comprises over 133,000 military and civilian doctors, nurses, and medical educators. So this is a very big and important enterprise in the government. We are also joined today by Dr. Shiriki Kumanyika. And Dr. Kumanyika is no stranger to anyone who has been a leader in the world of public health. She's a current president of APHA, as you know, and also an emeritus professor of epidemiology in the Department of Biostats and Epi at the University of Pennsylvania Perelman School of Medicine. She has an interdisciplinary background, something that's very important for building health in all policies, as we know, and she holds advanced degrees in social work, in nutrition, and in public health. In 2002, Dr. Kumanyika founded and continues to chair the African American Collaborative Obesity Research Network, which is a national network that seeks to improve the quality, quantity, and effective translation of research on weight issues in African American communities. She's also the former co-chair of Healthy People 2020 and is a member of the Institutes of Medicine. So I'm grateful to have Dr. Kumanyika and Dr. Woodson here with us today. They're going to share some opening thoughts with us, and then we'll transition to some questions. Dr. Woodson, we'll start with you.
Well, thank you, Dr. Murthy, for the invitation to be here, and thank you for your superb partnership over the last year as we've dealt with issues relative to the national prevention strategy, but also a lot of the issues in the interagency environment, which maybe we have an opportunity to talk about later, because it is about strong partners, both in government and out of government, that will win the day. But for the audience who may not be familiar with the Department of Defense, you may ask, well, why am I up on this stage? The Department of Defense, particularly the military health system, has had its foundation really in public health since its beginning. And just to give you an example about the important work, let's say, that Dr. Walter Reed did over a century ago to identify, vector-borne etiologies of yellow fever. We've always been involved in emerging infectious disease and public health systems, and continue to do that both in the United States and around the world today. But we do operate a system of hospitals and clinics, some 55 hospitals, over 600 clinics around the world. With the personnel that has been mentioned already, we're a medical education system, we're a public health system, we're a research and development system. We run a defined health benefit called TRICARE, and of course we're very much involved in community health. So trying to build healthy populations is very important to us, and some of the important goals that have been enumerated by the National Prevention Strategy are very important to us as we try and build a medically ready force and a force of health professionals who understand the principles about how to build healthy populations. We care for nearly 10 million individuals, and we have consciously moved from a system of healthcare that is treating already established disease to one of health, which is creating health in all dimensions and prevention. And so the concepts are very important to us. Beyond this, DoD is really a microcosm of society. The individuals that are in the service are your brothers and sisters, your mothers and fathers. They come from your neighborhoods, similar backgrounds to you, and so whatever issues that affect their health as they come up through the years will be part of their story when they're in the service. And so we need to understand that. We represent the diversity that is America, race, gender, and of course, as you've read in the press, even sexual orientation these days, socioeconomic status. We are affected by those problems that occur in society. So two of the principal issues that we've had to deal with is obesity and tobacco use and the effects. But of course, we also have to deal with the issues of mental health, which is important in terms of a holistic look at what health is all about, mind, body, and spirit. We spend about $3 billion a year on the effects of obesity and tobacco. And so we have platforms in the Department of Defense, communities in which we can actually use as laboratories to try and find out what works to build healthy populations. And that's led us to what we call the Healthy Base Initiative. We developed a few years ago an umbrella set of operations called Operation Live Well. Sounds like a very military term, Operation Live Well, right? But part of that was the Healthy Base Initiative, and it was really about building healthy communities. How do you engender active living? How do you engender healthy eating habits, reduce tobacco use, and building healthy communities? We employed evidence-based tools such as the military nutrition assessment tool, where we surveyed our communities and said, well, what's in the environment? How are we feeding our people? What's on the menus? Can we leverage our purchasing power in terms of what we buy? And we spend an enormous amount of money buying food. How can we leverage that purchasing power to get healthier foods within our eating venues? How do we change labeling? How do we change education? How do we change food presentation so that the healthy foods are the ones that are selected? How do we address nutritional education? How do we promote an environment in which the healthy choice in terms of activity, walking, bicycling, is the preferred? We found out when we went around to some of our installations that they actually had been developed to force people to drive from one part of the post to the other part of the post. Putting in bike paths, running paths that were scenic and encouraged people to do activity that was healthy for them was really very important. So redesigning the environment was important. Developing health promotion councils, so community people who were engaged and active and could actually change their communities based upon their individual leadership was important. Providing coaching and counseling across the spectrum of things that needed to be dealt with, nutrition, fitness, etc., was very important. So these are the things that we were after. And so we had some long-term goals and vision, which I'll sum up with, which were that we wanted to reduce overweight and obese individuals, understanding that, again, for us, we were finding that 27% of individuals who would apply to the military services were unfit because of being overweight, not making height, weight, and physical fitness standards. And that we were finding that the number one reason for involuntary separation from the service was obesity and not meeting health and weight standards. So we would invest all of this money in training individuals, and then they could not meet height, weight standards. But we wanted to decrease tobacco use, improve healthy living, and improve the entire environment. So there were many initiatives that were involved, and maybe we can get into that in the discussion, but that's just something about what we've been thinking about.
Fantastic. Thank you, Dr. Woodson. Dr. Kumanyika?
Thank you. Well, I don't work for the government, obviously. I'm going to speak as a public health stakeholder, looking at the National Prevention Council from a perspective of what it signifies to us, the hope and the opportunity that it signifies. And I'll speak from my perspective, thinking back to Healthy People 2020. I was, as you said, the vice chair of the Secretary's Advisory Committee, and we were a first because we were the publicly appointed APHA, Federal Advisory Committee. So not only were we outside of government, but we were required by law to speak on the public record. And that meant that we could say things that perhaps may have been thought of, in the government, but would be a little awkward to say, especially some of the more radical things or transformative. So we talked about upstream prevention from the very beginning. My sense is that the idea of the intersectoral sort of need in terms of getting to prevention upstream had been anticipated because the Federal Interagency Working Group that was assigned to staff the Secretary's Advisory Committee and to actually develop Healthy People 2020 included representatives from several different offices, several different cabinet departments. So we were encouraged to see so many cabinet departments detailing staff to work on these objectives, and we went forward to come up with our 4 overarching goals, and the cross-sectoral health and all policies approach was core to all of them: prevention, life course approach. But the 2 goals in the middle, the achieve health equity, eliminate disparities, and improve the health of all groups, and then create social and physical environments that promote good health for all. So that made it certain that we had to go upstream and we had to involve the other sectors. In fact, I wrote down some language from the very early Phase 1 report. Healthy People 2020 must compel its users to examine their role in addressing determinants of health that lie outside the traditional purview of public health. So we took as a reference point, I also do some public health work in the global sphere with obesity. We took as a reference point the health and all policies conversation that was taking place in Finland, in Australia. The Prime Minister of Finland, Ilona Kickbush, talking about this when she was in residence in Australia for a while. And we thought, well, that's the concept we need. We've been talking about that in here, these other folks. We weren't benchmarking in the way we are now against peer countries, but it had that same feel. Here are people who are talking about this, we can use their model. Well, there was one catch with their model, and the catch was that the European Union, for example, had a mandate to do this. Quoting from the treaty that established the European community, and this was in a report from Finland Social and Healthcare Department. This Article 152 on public health states, a high level of human health protection shall be ensured in the definition and implementation of all community policies and activities, being the European community. So that took us aback a little bit because we said, well, this is America. We don't have that type of structure. We are more of grassroots and blend and relationship building. We're not going to mandate this, that every agency has to have health in their policies. So when the Prevention Council was created, this is our chance. This is our health and all policies, but without the same type of mandate that you had. So then the question is, well, what can we do on basically a voluntary basis to convince, incentivize, reward these other sectors, these other departments for doing health and all policies? And that's what I've been listening for in the conversations that you've had so far, like what's happened and how did it happen. I heard Secretary Castro say, well, we're convincing people to do things in a certain way. but it's not that we are ordering them to do it. So I thought I'd throw out a few ideas from the public health stakeholder side about what we were expecting. I'll speak for myself. What I was expecting on Healthy People 2020, what the goal was. We talked a lot about aligning policies that conflict. Agriculture and nutrition policy, education policy, you know, the conversation about No Child Left Behind. So it was one thing, and I see that a lot of the groups that have signed up to Prevention Council and the strategy, we're finding health programs in other sectors. But we were thinking about the health consequences of the core programs in those sectors. And so looking at alignment and how could you actually align policies that are in different departments. I learned at that time, we were looking for harmonization, I learned the term wrong pocket problem in a conversation, a phone teleconference with the Congressional Budget Office. And I had not heard that before because I'm not really a student of health policy at that level. And I learned that the reward system doesn't allow the credit and the accountability for making changes to flow across the different departments. So we do something that affects health and we're wondering why people don't see in another department that this is great for you. Well, they can't get credit for it. If they do it, they can't be counted in the health sector. So that's my attempt to describe this wrong pocket problem. But the point is that if we're going to have health in all policies on a voluntary basis, don't there have to be some structural changes that allow the accountability and the credit to flow or the resources to blend so that we can really make these changes sustainable? So that's one thought that I had. Another one is linking the cost savings and the fiscal instruments using, politically unpopular I suppose, but using tax authority to incentivize changes in sectors in order to save costs in other sectors. So it's a version of the same thing in terms of making the resources flow. But I thought about doing that and how we would actually find those instruments and make those structural changes. I just mentioned the case of the Mexican soda tax. From my colleagues in Mexico who've been involved with that, they have a soda and a snack tax. The finance minister was really instrumental in seeing the opportunity to use those resources, not just for the general coffers, but to put potable water in schools and to do things to promote health programs. So that's another idea. I think the last thing I wanted to mention is the possibility that tripartite partnerships with the federal government, the private sector, and the public health sector might be a way to really maximize what the National Prevention Council and strategy can do. I think that public health has a role as ambassadors. We're trying to become more outward-facing, to learn about what's going on in other sectors, I guess that has big implications for public health education, to do health impact assessments, to provide technical assistance to sectors who want to do things in the health sphere, and to map where is health being influenced in your processes and how can that be mitigated in order to improve public health. The final thing I'd like to end with is this role of the private sector, which has been involved in a lot of the partnerships so far in health and all policies, is to really bear down on the private sector in terms of their stake, the for-profit sector, their stake in the social determinants of health. I think Dr. Rabowski said it in his opening talk. An educated population and a population with a humane living wage has got to be good for everybody's business. So I think that rather than only doing employee wellness and things of putting health programs at work sites, we can help to make the arguments and lift up those examples, and there are some examples of companies helping to educate the workforce that they then want to hire. So.
Well, thank you both so much for those wonderful insights. A few follow-up questions for you, and I'll direct these to one of you primarily, but feel free to jump in as well. We'd love to hear from both of you. The first, Dr. Woodson, reflecting on what you were saying with Operation Live Well, I remember the first time we had an NPS meeting, a National Prevention Strategy meeting and National Prevention Council gathering at DOD when I was Surgeon General. And I remember coming to the Pentagon, sitting next to you and hearing this incredible presentation about Operation Live Well and being so impressed by the work that you were able to do to shift and nudge people toward healthier practices. And so I want to commend you on that. And one of the things that strikes me about that work, which we've talked about earlier in the day here, is that this is, again, not just about putting policies in place, but it is about changing culture and attitudes. And in a place like DOD, where the culture is often very strong, how have you gone about changing culture to support health?
Well, that's a great question. The reason the Department of Defense exists is to defend this nation. A lot of things go on in the department that you would not think are health related. But it is about two things, really. One is about getting leadership investment in changing behavior. But in order to get leadership invested, you have to make the business case, and in the Department of Defense, make the readiness case. Readiness for us is everything. It's about having, again, medically ready individuals, to include their families, because of course families are enablers for folks to serve, and then making sure that the leaders understood that having a healthy force was in the national defense interest. So it's about aligning their interests with producing a healthy population. It was about making the business case, in certain sense, that changing the environment to create a healthier environment, to do the nutritional scans, to change the vending machines and what's on the menu was important to building a healthy, sustained, ready force. And then it has secondary consequences. When you address the communities, then you're talking about families. We run schools on our bases, and so it was a great opportunity to build at a very early age the student and the young involvement in healthy living. We tried experiments and we found that certain things work. So if you have recess before lunch, the kids eat and they drink their milk. That just changes their behavior relative to lunch. It's not in the garbage. So it was about leveraging everything we had in our environment, building the case, and getting invested leadership.
That is very interesting to hear. Dr. Kumanyika, it strikes me also that when you're talking about private sector partners, some of these similar cultural changes that we need to make are also at play. And one thing I think about often as Surgeon General, given my role as chair of the council now, is not only how are we going to advance the work of the council, but how are we going to reflect that in the private sector? How are we going to reflect that at a local level and at a state level as well, where we want these types of cross-sectoral collaborations, not just within government, but also engaging the private sector. So one thing I'd love to have you share your thoughts on are how do we achieve that kind of not just policy change, but cultural change on a local level when it comes to helping institutions understand the role they can play, but also when it comes to changing institutions in terms of their day-to-day practice? Because we know that when the rubber hits the road, when people actually have to change what they're doing day-to-day, where maybe they have to shift budget, a bit to hit, to fund another initiative, that's when we start running up against resistance. Yeah. So share some of your thoughts with us about how you feel we're going to be able to bridge that gap.
That is a challenge. I think there are a lot of examples in the nutrition, physical activity, and obesity area of successes at local levels. And I think it may be actually easier in some cases to do things at a local level that don't, where people have common interests and they're sharing the same community, and the stories are very personal stories, and the credit and the publicity are right there. This morning we had a panel that was put on by Let's Move, and we heard a lot of details from a mayor from Washington State and from people who work in early child care and in schools about how they actually were able to implement changes. And some of the principles that I can draw on that they were mentioning is first talking to the people, like the staff, the people who are going to be affected, not making the policy without consulting the community. And sometimes the community is staff, and sometimes the community are people living in that area. It's interesting how often people forget. You know, public health, we do know what's best for people, you know, and we sometimes get a little ahead of the population. And it's almost a guarantee for failure. So I think that's a possibility. In the business world, the business case for a healthy workforce is indisputable. What we probably need is better communication methods to tell those stories and make the case. I mean, I'm an epidemiologist, so bar charts, you know, make me smile. P-values and things like that.
I'm sure they make a lot of people smile around here. Don't worry, you're not alone.
But just seeing ourselves as persuaders and communicators. I have said this more than once. Being right is not the same as being effective. So for being effective, we need to see how are we being looked at, who are the stakeholders, how do we do that. It's basic human relations and relationship building, I think, at the end of the day.
That's absolutely true. You know, what you're saying reminds me of a question that came up when I was at a conference recently where somebody was asking me what I think the challenges are that public health is facing. One of the things I told them is that I think health has a marketing problem right now, which is that we force, or we don't force rather, but people think that they have to choose between things that are healthy in life and the things that are enjoyable in life. It's something I used to describe as the spinach chocolate mousse problem, which I describe it that way because it came about from what I remember as an experience at the hospital I used to work at, where the salad bar used to be next to the refrigerator that held the chocolate mousse. And I would see people standing there, right in between the two, trying to decide whether to get spinach from the salad bar or to get chocolate mousse from the refrigerator. And that choice, though, comes up all the time, whether it's in choosing something that's tasty versus something that's healthy, whether it's deciding what to do on a Friday night with your friends or your spouse. Am I going to sit on the couch and watch TV, or am I going to, make my way over to the gym and, put myself through this drudgery and pain because hopefully it'll prevent a heart attack in 40 years? Like, these are the kind of, and I say that not to make light of it, but in reality, this is the thought process that goes on within people, what sometimes subconsciously. How do we get people to, how do we solve that marketing challenge? How do we make healthier choices not just more available and accessible to people, but how do we make it the choice that you actually want to make, that you can't wait to make?
I think in part it's about what we attempted to do was build environments that made the healthy choice the easy choice, basically. If you provide bicycles, if you provide an appetizing, healthy menu that looks appealing, it's about aligning the incentives for making the healthy choice easy in the context of how families operate today with the demands on their time, basically. Are there things they can do together? Is it a sort of the tension between trying to find childcare and exercising? Well, if you design systems so that the family can play together and exercise together, that tension no longer exists. So the issue really is to understand all of the factors that come into play and try and help redesign the environment to make the healthy choice the easy one. So there's some marketing, but the real issue is to actually relieve people of having to make the choice almost, you know. It becomes natural.
I agree wholeheartedly. I think there's a partnering approach that also helps with this. We probably see it more clearly with children because we know that for children to do things, it has to be fun. So we let ourselves turn public health goals into something that people enjoy. We don't do that for adults because we're supposed to be doing the right thing. We don't have to do that. But there are actually a lot of organizations that are in the business of helping people have fun. One example, and doing things that are good for them that don't have a health flag anywhere but are good partners. And the one that comes to mind is the National Gardening Association. They spoke at an Institute of Medicine workshop on cross-sectoral partnerships, and they said, it's fine that this is healthy, but we're doing it because it's good for people in other ways. I think if we look for those partners, people in the entertainment and active entertainment, in gardening, in family life, we don't have to ruin what they're doing by telling them to tell people it's healthy. We can just partner with them.
Absolutely, yeah. Sometimes telling them healthy is the wrong thing to do.
That's right.
I run into folks who run restaurants who sometimes tell me they hesitate to label food as healthy for fear that people won't choose it, thinking it's going to taste bad.
That's right.
So that is a challenge. You know, one of the things that Dr. Woodson, you and I have talked about is the ongoing challenge we face in our country around tobacco. This has been, a lot of people are under the impression, no one here certainly, but out in the public, that we won the battle against tobacco. They remember the lawsuits years ago, they remember the master settlement agreement, they remember all the press coverage, and they think, okay, well, we beat them. But that's not the case. And while we made a lot of progress since the first Surgeon General's report in 1964 on the harms of tobacco use, we still have a large number of people who use tobacco. We still have many youth every day who are initiating smoking. And this is a real challenge. The Public Health Service Commission Corps, which I have the privilege of overseeing as Surgeon General, in recent years made a decision that they would not allow the use of tobacco products while officers were in uniform. And that was a long time in coming. It was certainly welcome. Dr. Woodson, you and I have talked a little bit about the other uniformed services and about how we can move forward with setting an example for the rest of the country about healthy living when it comes to tobacco use. This is not an easy subject. It's charged with all kinds of considerations, as you know better than anyone. And I was wondering if you could talk to us a little bit about how you're thinking about tobacco in the military and what people in this room in particular and in the public could do to help.
Well, first of all, thanks for the question, because in an audience like this, we should be talking about our ongoing challenges and what our strategies are for dealing with it, so that we don't think that the all set of issues of building healthy populations is solved. But I also want to make sure I thank you for your superb public health service officers that actually work for me in the Department of Defense and lend me great support in terms of shaping our public health policies. But to get to answering your question, we are particularly challenged in the military with tobacco because we have some interesting and somewhat adverse statistics, which, when I delved into them, showed me the interrelatedness of our history and the policies we had established that align the wrong incentives in terms of trying to reduce the use of tobacco products. And what do I mean by that? So if we look at the young Americans who come into the service, they reflect, as mentioned before, America's population at large. At 19 years of age, maybe there's about a 19% use of tobacco products. We found out that if we studied them after particularly basic and what we call advanced training, that rate went up to 27%. And so when you say, what is going on here, basically, what you need to do is look at your institutional role models and your institutional systems that have set up an alignment of incentives to actually not go to where you want to be for healthy habits in terms of reducing tobacco. And so we looked at what in fact was going on in terms of the pricing of tobacco on installations. We looked at the issue of, again, role models, those senior enlisted, those enlisted instructors, how they were being influenced in schools, and we recognized, in fact, that we needed to change certain things. So we've worked diligently on reforming the pricing policies of tobacco products to realign the incentives, and then to engage the senior enlisted in how they present themselves and some of their behaviors they model, so that we can reverse that trend. Now, the truth of the matter is it's still a difficult problem, but I think we've got a pathway forward to reduce the use of tobacco products. It will take a couple of years to see the effects, but I think what you really have got to do is look at all of these subtle historical relationships and incentives that you built into the system over decades and centuries, and try and untangle them. And I think that's what we're facing.
Thank you. One point, we talked about tobacco, which, as many of you may know, is one of the 7 priorities in the National Prevention Strategy. But there are also 4 strategies in the NPS, which I just want to remind all of us of. And those include healthy and safe communities, include clinical and community prevention, eradicating disparities in health, and also empowered people. And it's this last one that I want to focus on for a moment. One thing that we have, I think, increasingly realized is that if we want to create a foundation of health in all of our institutions in the country, this would be better supported if we were able to build a movement around health in the country, a movement where people felt empowered to speak up and to speak out for the changes that need to take place in their neighborhoods that will ultimately advance health, whether it's around sidewalks, the need for public safety in their neighborhoods, the need for better healthcare services, better food at school for their children, whatever it might be. And one thing I would love to get both of your thoughts on is, as we think about that 4th strategy of the NPS, empowered people, what are your thoughts on how we are going to engage people in communities to speak out and advocate for the changes that will ultimately make them healthier? Do you want to start?
That's a setup for Generation Public Health, isn't it? Thanks for the question. I think that what we're doing with Generation Public Health is just that, to get citizens, the average citizen, to connect with the public health agenda. And we're going to do it with stories, with ideas about things they can do, with making them aware of the things that are limiting their health, and giving them ways to speak out so that on a supply and demand type curve, that the people who are making decisions about the supply can actually see the demand for a healthier environment. One of the dangers of changing environments without having this empowered population is that you won't have sustainable changes, or that people will feel like it's an imposition on their lives. And I think that's especially in communities. I mean, I work in African American communities, and the idea that all of a sudden the government has decided to make your community better doesn't always play. So it's critical that we empower people, and I think it's going to be conversations and showing people that they do have not individual control over some of these things that seem to be just taken for granted as promoting poor health, but that collectively people do have that ability to change things. And with, again, I go back to the food and nutrition area, because we've done some things in communities now over years of fighting the epidemic that people thought couldn't be done. People said, those corner store owners don't care anything about us. They're just in here to make money off the community. And now you have all these transformations. And you realize that they're business people, and if they can be talked to and they're customers, you use my store if I can sell you some better food. So I think there is potential, so we need to be specific, and we need to be inspiring to the average person and bring them along to raise their voice.
So I would answer the question in a couple of ways. One is about understanding that promoting health is not primarily, well, it will not be received as effectively if it's seen as primarily the responsibility of health professionals. That it really requires creating broad partnerships with communities and leadership within communities to, again, make it relevant to the communities and how they must transform in order to create safe communities, healthier communities, and the like. So it's about partnerships with non-governmental agencies, faith-based agencies, community services, schools, you name it. But if it's seen primarily as the responsibility of health professionals, it's an uphill climb. The second thing is about giving voice to the important minority. So we just talked about the issue about tobacco, and we talked about the 19%, let's say, of young adults that smoke, or in the military, the 27% that use tobacco. But what that means is, in fact, that there's anywhere from 73% to 81% of folks who don't use tobacco. And so when you go into housing, particularly communal housing that you might find in military, on military posts and installations, it's about giving voice to those people who don't want to have the secondhand smoke, to create the right balance in terms of the environment so that it's not seen, your new policies are not seen as denying people their freedoms, but it's about enabling the majority to live in a healthier environment. And people respect that when you turn the equation around. So it's about giving voice to the people who want to live in healthier communities, safer communities, and the like, and empowering them to be the message bearers. That circles back to the first point I'm making. If it's seen primarily as an effort of health professionals, it's an uphill climb. It's about the marketing that you talked about before. But when we can engage, empower, and energize and motivate communities, I think that's when we'll win the day.
And Dr. Woodson, you mentioned interagency collaboration, and I want to pick up on that thread in the last few minutes that we have. We know from our work on the National Prevention Council that the more we can get agencies to not only work on health independently, but to work together, share best practices, have shared goals, the better off we'll be. As a collective, we are trying to advance certain goals across the federal government when it comes to tobacco, when it comes to nutritious food options that are offered hopefully on all of our campuses. But in your experience on the council, what do you think we need to do to promote more of that interagency collaboration, particularly at higher levels within each department?
So again, 2 points is one about engaging the leadership, and I think you and I and several others have had some very involved conversations at the National Defense University on how do we build a new type of leadership to promote a healthier society. What it requires is what we call meta leaders, leaders to lead across domains. We're so traditionally attuned to leading within our authority lines that we don't actually lead across domains where we're going to really get transformative change. That brings up the second point, is that within the federal government and the interagency environment, it turns out that if you look almost across all of the agencies, when you're developing policy, every agency can do something to move the ball a little bit further. And so that's why I'm so excited about your theme for your 143rd annual meeting, Health in All Policies, because it really is about that. when you get that, one of the things I've been so impressed with the Obama administration about is that, you know, we've now, and I've now certainly served on a number of task forces. It's about leveraging all of the assets of the interagency to try and move the ball forward. What is it you can do within, let's say, agriculture? What is it you can do within education? What is it you can do in health and human services? What is it can you do in the Department of Defense? There is something within that broad government agency that can be done, which when synergized with the other agency moves the ball forward and elevates the platform for change. And so I think that's what we've got to do in all of these very hard issues in creating healthier populations, safer communities, is ensure that every agency, every policy reflects something that moves the ball forward.
Absolutely. Well, Dr. Kumanyika, I want to give you the closing word here. And what I'd love for you to just reflect on with us is as we think about the future, not just the next few days, but the years ahead for public health. I know you feel hopeful, and I can tell that based on what you've said and some of what we've talked about earlier, what you've said and written earlier. But what I'd love for you to share with the audience is what makes you hopeful, and what do you think we need to do to achieve the goals that Generation Public Health has, that we've set forth of having health reflected in all policies?
I think what makes me feel hopeful is my belief in people. I used to be a social worker at one point. I always think that finding a positive goal that people can share is something that will get us where we need to be. And I think that the goals we have now are in fact very positive. The health equity goal, as I mentioned in my remarks yesterday, the health equity goal could be the transformative goal that puts the whole conversation on a different footing. Because when you talk about health equity, you can see that people still believe in justice. And they want to be a part of something that's rights-based and that will lift people up to do their best and have their best opportunity. So I think that we just haven't been using the right arguments, haven't been using the right language, and paying enough attention to the positive things that we can do together. Health in All Policies is a perfect platform for doing that, and health equity is very closely related. So even though I was raised in a segregated community in the first part of my life and so forth, I've met wonderful people who believe in equity all of my life, and there are more coming, especially the younger generation, coming down the pike. So that's what makes me feel hopeful. Thank you.
Well, that is certainly a wonderful note to close on. And I should say in closing that I too feel hopeful. And one of the reasons I feel hopeful is because we have leaders like both of you who within DOD, who for the entire country are helping people to come together around public health to move some of these extraordinarily important goals forward. Yesterday, I said that the pursuit of health is the pursuit of justice, and I firmly believe that. I think that through health, we have the opportunity to create the kind of country that reflects our highest values, values around equity, values around opportunity, opportunity that's available to everyone. So I want to thank both of you, not just for your work advancing the National Prevention Strategy, not only for your work at DOD and APHA, but for helping us to create that more just America. Thank you both so much.
Thank you. Thank you.
Thank you so much.
Let's give our panel a great round of applause as they